Time now for this week's Health Matters. Paul Critz along with PA Lynn Szabo and a little wake and bake this morning. It's the topic of today's Health Matters is cannabinoid, and I've forgotten already how to say it.
Cannabinoid Hyperemesis Syndrome.
Cannabinoid.
Yeah.
Hyper what?
Hyperemesis.
Okay. What's that a fancy word for? What's that saying?
Vomiting too much because of pot.
Oh my God.
There's a syndrome.
Ooh.
So there's a lot of cyclic vomiting syndromes in gastroenterology, but when it was first described in 2004, but we've seen more and more and more of it, is this cannabinoid-related hyperemesis. So it's a syndrome that has abdominal pain, mostly vomiting, a little bit of diarrhea occasionally, and it's related to, weirdly, too much pot. So kind of super interesting. It actually, people have kind of pain around their belly buttons. And what we see is usually 2 or more episodes in 6 months. So mostly people feel okay, and they just, they have a bad couple of days and they make the vow to never eat at that restaurant again. And they don't think about it.
Wow.
And then they get sick again. So it starts within 24 hours of last use, but it can also be random. But here's the trippy part. And so people who are aware of this or maybe lived through it before know that hot showers or baths can actually bring temporary relief. And so a lot of people get anxious and they take like 6 hot showers a day. Just to keep from feeling miserable.
Oh my goodness.
So it's totally associated with long-term daily pot use, and more so in young men for some reason. More common with smoking than edibles. But the metabolic pathway, I had hopes of maybe addressing that because it is a real thing. They can plot it out molecule by molecule what's happening. But super complicated, and so I kind of gave up on that early. But,
which molecule were you trying to track?
There a bunch of them.
A bunch of, okay, yeah, that would be complicated.
So, but the end result, the bottom line is that the blood is shifted away from the visceral organs, so the guts, the human being's guts, and shifted to the visceral organs and away from the skin. So you have an imbalance of the blood in the body, and it's focused on the stomach, and mostly stomach, but also intestines, and it makes people feel uncomfortable, and that's why the hot showers work, because you're bringing blood back out to the periphery, right? And it's seen with high THC content products. But remember, we always forget 2 things about pot. One is there's no such thing as organic pot, ever. And secondly, when you're talking about pot, you're talking about way more chemicals than THC.
Yeah.
Okay. The focus is on THC because it's being bred to be more THC, higher like THC dominant content.
Yeah, sure.
But there's greater than 400 other chemicals that are barfogenic, as we say in medicine. That'll make people throw it. Okay?
Okay.
So it could be a lot of different things. And this is what blew me away. When marijuana was legalized in the places it's been legalized in the United States, and this also includes Canada, there's about a 60% increase in frequency. In this
of the hyperemesis?
The hyperemesis. So...
well, yeah, that makes sense.
Yeah.
Sure.
So you're seeing people are using more, they're using higher THC products. Maybe there's another cofactor in there because, like I said, the chemistry is super complicated.
I wonder if you could extrapolate from that increase then how much, how many casual users or how many new users came into, people, it's legal now, what that did to the demo of pot consumers. And that if this instance went up 60%. I'm not
sure enough is known about it to be able to do that. I'm not sure that anybody's looked at, there should be so many confounding variables.
Well, right. And then when you reach the final line, you come up with, they don't know what causes this either.
Right.
Yeah.
Yeah, totally. Well, they do. They know it's THC and maybe some other stuff.
Well, okay. come on, I'm going to call BS on that. You're going to say, "Oh yeah, they do know," and then include maybe in your in your explanation. Yeah, that maybe, and I do know.
I will give you that, because there are some things that are not understood about it. There, number one, there's a lot of cyclic vomiting syndromes, unrelated to pot. So that's the diagnostic challenge that the primary care person and maybe the gastroenterologist has, to not just nail somebody for pot, when it could be something else.
Sure.
And miss something important. But also, there's also compounding variables about why do some heavy users never have the problem, and some people do. Why do more men than women have the problem?
Right.
Why is it association? There's an association with anxiety and depression. Why should that be? If it's, and why isn't it universal?
So it was trying to track down answers to those questions. Is that what got you trying to track like the metabolic pathways of all these different molecules? I mean, because that's where those answers would be, right?
Maybe, but there's so many compounding variables. But and then if you say that to a patient, if you're in the exam room and you say, "Well, I think you have this cannabinoid, hyperemesis syndrome," then what that sounds like to patients is, "You pothead, just stop smoking," and that sucks all the air out of the room.
Sure,
There's like no productive way that goes.
Well, there's no there's no way to do that.
Yeah.
So how do you do that? How do you broach that?
How would I do it? I would not jump to it because it's a clinical diagnosis. Okay. I would not jump to it immediately. It's possible that diagnosis is best made at the gastrointestinal level, of which we have 0 in this county.
Oh, wow. Okay.
But what I would say is, look, here's possibilities. Do you think this could be a possibility?
What other cyclic vomiting syndromes are there out there to sort of muddy the waters?
Well, migraines, abdominal. Some people experience migraines as vomiting and abdominal pain.
Wow.
Yeah.
Okay.
I had that actually myself as a child, and people just thought, "Oh, now Lynn's going off again." So what I'm saying is that we don't understand a lot about this.
Right.
Crohn's disease could be and that's a big one that you don't want to miss. I imagine that out here, somebody could have, like, if they're on well water or have been traveling, could be a travel issue. Everybody here universally blames the restaurant that they went to. It's interesting. Almost any time anybody vomits and it's unexplained, they blame it on a restaurant.
Sure.
Even though food poisoning is very seldom seen up here.
I get it, but that logically makes sense, because what's your head going to do? You're going to go, okay, I'm vomiting now. This is new. What have I experienced? What stimuli have I experienced that is new as well?
Right. That's why oftentimes gastrointestinal specialists will tell patients to keep a journal, a symptom journal.
Sure.
That becomes super important.
Wow.
You could also, this drops down a little bit further. You could also confuse it with small bowel obstruction, which is an emergency, bowel ischemia, another emergency, gallstones. I mean, there's a lot of things that it could be confused with.
Is it a good rule of thumb if you're experiencing cyclical vomiting syndrome of any stripe to go have it checked out?
Try to look at it in the bigger picture. So don't just look at it as one episode of nausea and vomiting, and then 3 months later, I should have never gone back to that restaurant, kind of scenario. So try and look for patterns. And I would, certainly seek care from your primary care person. Try to step back and look at a bigger picture of it. That's why a symptom diary can be super helpful.
Wow.
But you know what? These are also symptoms of cannabis withdrawal.
Oh, geez, really?
So the cyclic problem starts greater than 72 hours after last usage.
From withdrawal?
Yeah, sorry,
okay,
I said it backwards.
Gotcha.
Withdrawal is greater than, withdrawal is greater than, there's a time period.
Right.
You go through and then you have withdrawal. This is random.
Okay.
The cyclic hyperemesis is random. Okay. And the cool thing is there's lots of treatments for it. This is where it's important. This is why I wanted to do this talk. Okay. So what patients hear is just stop smoking pot. That's not really what providers are saying. what they're saying is be aware that you have this. Pay attention to your symptoms. There sometimes in some people is a recognized prodrome. That's why symptom diary is important. Medication can be given that just stops the episode when it's early, kind of like migraines. You have migraines, the first time it occurs to you, you're having a migraine, you take medication that cuts it off, same deal. And then there's also, and this is probably best done with your primary care person, you can have a formula that works for you in treating this. And so when you get to the emergency room, you're not just branded crazy, drug seeker, anxious person, So you can, I don't know how to say it, legitimize maybe? Not only that you have this medical diagnosis, but there is a way to treat it.
Right.
And here's the recipe.
Wow.
And people who work in the ER really like that. And oftentimes they do that with migraine sufferers. They know their triggers. They know how to maybe abort a migraine episode, and they also know how to treat it, and it's not just Dilaudid. Okay.
Wow, okay.
Or it's not just a narcotic. But for this particular syndrome, opioids and benzos might be the go-to, might have been the go-to in another time, but it's not really the go-to now anymore.
What is now?
Haldol.
Okay.
Are you familiar with Haldol?
I've only heard the name.
Yeah. So Haldol is an antipsychotic drug, usually given to sedate people.
Okay.
And I think what it sounds like to the patient, again, it's not only you're bad because you smoke too much pot too often, but you have to have this crazy person drug to get better. But what it really is to the medical person is, this is an anti-nausea medicine that's very effective and not commonly used because there's like a little bit of stigma about it.
Sure.
Yeah, so Haldol. But there's also other things you can do, and so that's why it makes sense somebody is eventually going to need rehydration, right? Because they vomit like 30 times in a day.
Oh, wow.
I mean, they're miserable. And so the only place you can get rehydration really is the ER here. And then if you go in with a recipe that's not opioid benzo dependent, then you make it really easy for the doctor that's seeing you.
Wow. Okay. So can you give an example what that recipe might look like?
Well, the cool thing is that what we would normally use for anti-nausea medicine, the first, second, third line of anti-nausea medicine, like Zofran is the dissolvable one in the mouth. It's also called ondansetron. That's what any doctor or provider in the ER would reach for. Those don't work with this. Okay. And so going for the older ones like Haldol, other things probably. You got to make sure your electrolytes are okay, because when you're vomiting that much, I would worry about sodium and potassium. There is, it's so variable. It kind of is dependent, but there's the two older anti-nausea medicines specifically. There's Phenergan, which is known now by the brand name promethazine, and Compazine.
Compazine, okay.
Yeah, so Compazine is one that I don't think most people would think of. It has a couple of side effects that have made it fall out of favorable use. So that would stop the vomiting. And mostly all these are going to sedate people. So you're going to be lying there kind of drowsy while you're getting your electrolytes and fluids balanced. And that's, I don't think there's any role for anti-anxiety medication, but it kind of depends on what your personal recipe is. That's why I think providers need to reach out to people that have this and give them a tool that makes sense. And so I don't think the conversation should end with, well, you just got to stop smoking pot.
Right.
That is recommended. That's a reasonable recommendation, but
Sure.
They're not saying like until Tuesday. They're saying for 6 months. It takes 6 months for all these receptors, these enzymatic receptors, to recalibrate.
Really? Wow.
Yeah.
Wow.
Yeah. kind of interesting.
That is.
And then maybe if somebody restarts cannabis use, that they go maybe more for edibles instead of, smoking. So change your method of ingestion, I suppose. And then,
do you ever think, as a healthcare provider, you'd ever publicly offer the advice to change the way you consume marijuana?
no, I didn't see that coming.
Yeah.
But I dropped, as is well known in the community, I dropped into the AIDS an AIDS practice pretty early on, and marijuana was something that it was a medicine that we used long before it was recognized as a medicine.
Right.
So, and also, by the way, marijuana showed up at any provider that I worked with that happened to get a cancer diagnosis, personally or within their family. I mean, pot shows up immediately.
Wow.
We just don't talk about it.
Yeah.
So if somebody has this, I think they've got to, I think they've got to stop hearing everything their doctor says is judgmental and negative, and reach out on a plane that's more functional between provider and patient, and create a plan. So the reason I picked this topic today is because I'm listening to a podcast called Curbside, and they had a physician who was a gastroenterologist, and she was talking about cyclic vomiting syndromes in general, and this one came up. And she was an entirely reasonable person in her way that she treats people with this particular disorder. And I thought that her ideas were A, refreshing, and B, worthy of comment to people in the community who might have this problem. It doesn't really mean get off pot for the rest of your life. What is probably a good idea to change your consumption and maybe abstain for a little bit, kind of like, like we just had no alcohol January, stuff like that.
Right. Take
a break from it for a while.
Is it important to take like a 6-month break to allow everything
to? Yeah, it's critical.
Yeah, okay.
Because those receptors are that are causing the problem, and this is where it gets way more complicated than I'm ready to talk about. But that's what it takes for them to reset. So it's not like you can just be off of it for a couple of days and then switch to edibles. It really needs a dedicated.
Right.
You have to get over the actual withdrawal from THC.
Wow.
Because apparently that can confuse this whole clinical picture. I think it would be nice if there was a way to diagnose it that wasn't really, do you take a lot of hot showers? Because right now it's a clinical diagnosis if there was an actual test. Because a lot of people can rely on hot showers and nausea, and they don't have this. They have something else.
Right.
So it's just not specific enough. That's kind of also the problem. And again, Del Norte doesn't have the specialty care that would be best to address this with. Although I bet you could do telehealth maybe with UCSF or something. But
how would you even find out? I mean, I don't even know. You got to go and you'd have to get referred and all of that, right?
But here's the problem. If people have this and it's not recognized, that means every time, especially with the abdominal pain component, every time they come into the ER or present to their primary care person, they're gonna kind of precipitate a huge workup. And oftentimes this includes a lot of CT scans of the abdomen. And remember, we've talked about that before, that the radiation is not like a free pass.
Right.
Is that it has effects on the body. And like I mentioned before, 1 out of 100 CT scans that I order are going to result in somebody getting cancer.
Wow.
So it's not like we do CT scans as willy-nilly as we used to. And they're probably... and a CT scan of the abdomen doesn't include the pelvis, and maybe you need, if the pain is nonspecific and diarrhea, maybe you also need a pelvis one. So what I'm saying is, not only can this become expensive in terms of radiation, but expensive in terms of funding if somebody doesn't have great insurance, expensive in terms of time, and then it's such a loaded, no pun intended, discussion between, there's no great place yet for provider and patient to meet in a meaningful way, because it sounds like your mom's scolding you.
Yeah.
And that's unfortunate because it's not at all productive.
Wow.
Yeah.
Yeah, I can see the challenge, of trying to maintain some sort of perspective on this. If you're a heavy pot user, then you're messing with your chemistry. It's not all just, it seems like, especially among pot users, like marijuana has this kind of, nothing bad can ever come from it, and that doesn't seem, of course, to be the case because you're ingesting this thing.
But also,
chronically.
pot is seen by a lot of heavy users as their medicine.
Yeah,
they identify it as medicine.
Right.
And right now in medical practice, we're kind of taking away a lot of stuff from patients. If you think about it, the whole chronic pain thing with opioids like disappearing.
Right.
What we're doing, when I talk to a chronic pain person, I talk about chronic pain toolbox and stuff. I've talked about this before, but if I put like 20 things down, I'm only responsible for providing like 3 of them. Okay. And the patient's responsible for doing the rest.
Right.
And so you're really offloading provider responsibility onto the patient is what providers see as a good thing, and patients are like, but I came here for help.
Right, yeah.
Yeah, and if
God.
I say, okay, do 150 minutes of exercise a week, and if your knees hurt, maybe make it pool exercise or something. That doesn't sound like help.
That doesn't help. That's homework.
Yeah.
Make me better.
Right, you don't understand.
Oh my gosh.
The hydrocodone made me better, but only for 4 hours, and then stuff was back and worse because, pain experiences change and stuff.
Right.
But so I'm hoping people out there will be able to take this information and talk to your provider. And it's possible your provider doesn't have this information. So I got most of mine in Up to Date, which is a pretty easy resource for providers to access.
So you can go drop something on your doctor. You can go, hey, I think it's this.
Yeah, or listen to the Curbside. You could totally listen to the Curbside podcast. It is, oh God, it's wonderful. It's like going to medical school again.
Oh wow, really?
Actually, it's super cool.
What's the podcast? Who's in it?
Well, I don't know their names offhand, and I probably
is it the same people every time? Is it?
It's the same 3 doctors, physicians every time, and then they have like a couple of specialists come in, and it's for like an hour and a half, and I'm like enthralled.
Wow!
Yeah,
oh, that's wild. That's
super
fun.
Enthralled in learning a lot of new stuff.
It's like my son with D&D podcasts.
Yeah.
Well, Lynn, thank you very much. Any thoughts about next week?
Yeah, I'm looking at anemia because it's another misunderstood disease.
Wow. Okay.
Yeah.
Okay. All right. That we'll take care of that when the time comes, and bring that message to you about anemia. It's Health Matters. Lynn, thank you.